Hey guys, welcome to Thrive Bites Podcast. I'm your host, Dr. Colin Zhu, and thank you so much for listening on. You could have been anywhere in the world and you decided to spend just a few moments of your precious time, and we greatly appreciate it. Here on the podcast, we talk about three things: living a plant-powered lifestyle, enhancing emotional resilience, and creating a thriving mindset. And I interview a range of passionate guests such as physicians, dietitians, coaches, entrepreneurs, and many more. And please join me as I deliver these engaging, informative, and high-valued conversations for you. And just remember, the first 5 seasons of the Thrive Bites podcast can now be found in the Chef Doc app, available in your Apple Store and Google Play stores. So what are you waiting for? Come on inside. Hey guys, welcome to another episode of Thrive Bites Podcast. I've had a wonderful, guests, that I just did that you're going to appreciate and love. So the next episode is with Dr. Mahima, and she is a triple board certified physician, including but not limited to endocrinology and lifestyle medicine. And this episode is really special because we dive deep into diabetes. We talk about what it means to be in remission, right? To live a life without, diabetes, using lifestyle medicine. What are the light bulb moments that she's had in order for her to, transition to this stage in her career? And what does it mean to have a personal and professional support system? You don't want to miss this, and we'll see you guys inside. Okay, guys. Well, welcome to another episode of Thrive Bites Podcast. I'm your host, Dr. Colin Zhu, and thank you so much for being here with us. You could have been anywhere in the world, and you decided to share your precious moments with us, and we greatly appreciate it. So our next guest for today, I am thrilled to introduce Dr. Mahima Gulati. She is a triple board certified physician in endocrinology, diabetes, and metabolism, as well as internal medicine, as well as lifestyle medicine. She is the medical director of lifestyle medicine at Middlesex Health, and she's also tasked with creating the strategic vision, formulation, and the tactical implementation for this program. Sounds very, very nice. And she loves combining all these different pillars to care for her chronic patient population. She's also the senior staff attending for the endocrinology department, which, encompasses a whole host of conditions, not just diabetes, but also things like various hormonal disorders, pancreas, thyroid, adrenals, pituitary, you name it. She addresses it as well. And she's also the associate professor of medical sciences at French H. Netter. Our esteemed anonymous School of Medicine at Quinnipiac University. So we can spend all day long, and she's also the board of directors of American College of Lifestyle Medicine. We can spend all day long talking about her, but without further ado, please welcome Dr. Mahima. Hello.
Hi there. That was so kind of you, Dr. Zhu. I really am so grateful and so honored to be here on this platform with you. Thank you so much for your kind introduction. You were very gracious, and it is my real pleasure to be here.
Well, the pleasure is all mine. I can't wait to dive deep. Diabetes obviously is a huge topic, pun intended, right? And no pun intended, right? Mm-hmm. But before we get into the nitty gritty, I love talking about the origin story, the superheroine origin story of my guests and how they got from point A to point B. We were talking a little bit offline. I read this wonderful article about you, and you had this beautiful, light bulb moment. And I definitely want you to share that. So if you can share with the audience, how did you go, from a super specialist to a super to the nth power, specialist, involving lifestyle medicine? How did you make that transition for yourself?
So thank you for asking me my own story, actually. And thank you so much for saying those kind words. That really means so much to me. That's very special to me. I actually had hit kind of a rock bottom professionally, even though I was doing very well from the external viewpoint. Right after the birth of my second child, I had gone back to work part-time because he was preterm. I had no idea why he was preterm. He was more than a month preterm. And we spent 23 days, close to a month in the NICU, the neonatal ICU. And looking back, I feel like there were things with my lifestyle that I could have done better to have a healthier pregnancy, even though I did not have, things like gestational diabetes or preeclampsia, etc. But there were problems with my diet, with my sleep, with my stress management, etc. So anyhow, this was a time when I needed to go back to work part-time. And I just couldn't figure out the meaning or the purpose of my being there with my patients, to give your audience a little bit of perspective on an endocrinologist's life. In our country, we have a prevalence of diabetes that's almost 12%. So that's a huge prevalence of diabetes. But a very, very small fraction of those patients with diabetes will actually get to see an endocrinologist. That's because there's just very few of us. There's not enough trained endocrinologists. There's just not enough fellowships that train people in endocrinology. So, what happens is typically people with diabetes are managed with their family physicians or their pediatricians. And by the time they make it to an endocrinologist, they have already had diabetes for years, sometimes decades. And they are already, facing a lot of complications like retinopathy, which is eye damage, or, they've already had amputations, which is severe nerve damage leading to, basically severe infections in the foot, etc., right? Or they've had kidney damage, etc. They've had heart attacks, etc. So they come to us in what you could call end-stage diabetes. And, they've failed multiple medications, and then their family physicians are like, okay, now you need to see a specialist because you need to start insulin. So that was the profile of patients who came to us. And, like you mentioned, even for other hormonal disorders like thyroid conditions, again, thyroid conditions are extremely common, especially these days. Over the last 2 decades, the prevalence of thyroid disorders has really skyrocketed. And so people really struggle. They take levothyroxine or Synthroid, or they're taking Armour thyroid, and they still feel symptomatic, even if their TSH is normal. And that's when their family physicians or primary care physicians send them to an endocrinologist if you're struggling with, this formulation of thyroid or that formulation of thyroid. So again, they get to see us when they've already had thyroid conditions for a good amount of time. So we got the most complicated patients. And, when people come to us with something that is, in its disease stage, severe, right? You're treating severe disease. You also want to give them sort of a therapy which is equally, not severe, but equally high intensity. You are going to treat something that is, sort of an upgrade on pathology with the best of therapy. And I wasn't doing that. I would no endocrinologists were being trained to do that. So if somebody has to be started on insulin for type 2 diabetes, now, thankfully, we are questioning the merit of insulin and type 2 diabetes, and we're realizing that there are so many other things we can do before we give people insulin, right? Thanks to, the newer, fancier pharmacotherapy drugs that we have now. But, by the time people are started on insulin, and, if we are not addressing the elephant in the room, which is their lifestyle, if we are not telling them to, eat real food, and, they're on the diet that they've always been on, but we give them, 50 units of insulin or 60 units of insulin. And every time they come to us, all that I do is, okay, let's increase this insulin. Let's put you on this insulin before lunch, dinner, and, before breakfast. But I don't do anything to, make them move more, or make them eat differently, or make them sleep better, or make them manage their stress better. Then the therapy I'm giving is ineffective, really, or, very partially effective, right? And so I had started to figure that out, that, I'm not doing the best I can. Am I bringing my best treatments to the table? I was not. And there was this, nagging dissatisfaction in my heart. At the same time, there was also this, undercurrent of, being productive as a physician, which I think a lot of our physicians know about, being, producing a certain number of relative value units, or RVUs, and seeing a certain number of patients every hour, right? So there were all these different conversations going on in my head. Am I doing the best therapy I can? Am I being the most productive I can? Am I really making the best use of my time, getting the most value out of the amount of minutes I spend in a patient's room? And I'm like, okay, I need more enlightenment. There's something missing in my learning. It's not, there is definitely a missing piece of the puzzle, right? So I came across on social media, I think it was on Facebook, this Harvard Conference for Women Physician Leaders. So I knew I was a physician mom. I didn't think of myself as a physician leader back in those times. This was 2016 or 2017. because I'm working part-time and I feel like I'm a normal run-of-the-mill physician. But anyhow, I, took the chance to go. My husband encouraged me. He's a physician himself. And he said, you should go out of your comfort zone. This may not be the kind of thing you've ever done, but you should look it up and go there. And it's in Boston, which is close to me. So I went there and, I met the most brilliant pioneering physicians there. And one of the people I saw there was Dr. Beth Frates. Who, like you and I, she's been on the board of directors at the American College of Lifestyle Medicine, and she's now the president. And she was doing a session on lifestyle medicine, and she was very happy. She was hula hooping as she's teaching. There was a breakout session, and she's hula hooping in that breakout session.
Go back 2 seconds ago. You said that she was very what?
Happy. She was very happy. Yeah, and that's key.
What's that?
I'm going to tell you a little bit about that happiness part, because that's, critical to my story. So, I saw that moment, and then somebody tweeted about it. And, I replied to her post, and, Dr. Frates was very gracious to interact on that tweet. And then I went back to Lifestyle Medicine Conference at Harvard, which was, I think, 7 or 8 months later. And I met her again. But coming back to that happy moment, right? When I saw that picture stood out to me, because this is a happy physician who's possibly, maybe she wakes up in the morning and she is like, oh, I can't wait to go and, do my work today. And this looked like the opposite of me, because I wasn't there in that stage of my career. I had gone there looking for a missing piece in the puzzle. I was looking for that sense of meaning and purpose. And here I see a woman physician, who's enjoying her work, who is happy at work. She was present in the moment, right? She's not looking at a computer, clicking away, whereas the people are talking to her, I don't know, the air around her. And so that picture is still stuck in my office to remind me what it means to have joy at work. And then, the fact, lifestyle medicine, those two words also were very kind of like, sort of made the ground underneath me slip away, right? I'm like, lifestyle medicine?
What is that?
What's that?
What is that? Yeah,
here I am, by that time, I think I had already been a fellow of the American College of Endocrine, and I am, board certified in internal medicine, and I've been treating diabetes and endocrine patients for over 5 years, 7 years. I've never heard of lifestyle medicine.
Never.
What is that?
During your school training, nothing.
No, and it wasn't mentioned in my endocrine lectures. I had heard of preventive medicine. I had heard of integrative medicine, but lifestyle medicine was kind of a mysterious, curious term for me then. So I went back and I listened to her Harvard talk with her medical students on YouTube. And then I went to the conference and I met her. And, she had, not just her, but the whole conference was really sort of a really groundbreaking experience for me. So that's how I came across lifestyle medicine. And, thereafter, I became the spokesperson for lifestyle medicine at my health system, which is Middlesex Health System in Middletown in Connecticut, where I live. People there were thankfully very interested in lifestyle medicine. I have colleagues here who are also board certified. So, one of my colleagues said, let's do a grand rounds on it. And my chair of medicine really was very heavily interested. And in fact, she herself took the time out to go to that leadership conference at Harvard. And she, sponsored me to go get board certified in lifestyle medicine. And she wanted me to bring that service line back to our health system. So, over the years, then with the help of other colleagues, we had residents who were interested in kind of formalizing this as a track in family medicine residency. So long story short, we've built a complete service line. We have multiple providers. We have not just physicians, but also, physical therapists, dietitians, other healthcare professionals, including social workers and psychologists who work with us as a team. And, we've done numerous sort of news media outlet kind of blasts. We have created a referral system internally so that patients can be referred by different physicians, by your GI doctor, by your PCP, to come and see us at Lifestyle Medicine Program. And, it happened over a period of time. We actually did, our biggest annual symposium is supposed to be this whole day event. It's actually the whole morning, a session of 3 or 4 talks. And we invited Dr. Frates as our keynote there, and a few other, renowned speakers nationally to come and talk with us about lifestyle medicine. So over the past, I think now it's been 5 or 6 years that I was able to really re-infuse my professional life with the sense of meaning and purpose that I had gone looking for, the missing piece in the puzzle, which was, now if a patient comes to me and they may come to me for something that they're not even, they may not have any kind of, lifestyle issues at all. They might come to me for a thyroid nodule or an adrenal nodule, which, adrenal nodules may or may not be related to your lifestyle, but they still have to fill out a questionnaire. How many vegetables are they eating in a day?
Yeah.
Because that's like part of the intake form. And how many, servings of, let's say, whole grains are you eating in a day, etc. So I think this was the missing piece of the puzzle.
Yeah. Yeah. That's awesome. I think there's a lot to tease out from that portion of it that you shared, and I appreciate you sharing. The biggest takeaways that I got was, your husband, you went to get the information, you brought it back, your healthcare system was very supportive, right? Your colleagues, your peer, they wanted you to start a program. These are so instrumental, what you just said. I've heard of other stories where their spouse or partner was skeptical, right? They, just didn't know what it is. Oh, you can try it if you want, right? Their system and backing and support system, wasn't there for them. So there's certain key things that happen in life, however it happens, when manifested, really, really sets you on a exponential trajectory. And if you can imagine for a second, if you didn't have that support system, would you have been here, right?
Oh my God, you are so wise, Colin. Dr. Shiv, you're amazingly wise. I cannot believe how amazingly wise you are. You're absolutely correct. If I had not had the support of, first of all, my husband, who's been my rock, whether I wanted to do plant-based diet or, kind of go to this conference, which I actually was completely skeptical. He's the one who said, oh, if you never go outside of endocrinology and, outside of your comfort zone, how will you learn something that, you possibly will benefit from? So he has been the biggest mentor that I have ever had.
Yeah.
And you're absolutely correct. I know we're going to talk about diabetes remission down in this podcast. And one of the biggest success predictors for people to go into type 2 diabetes remission and stay in remission was spousal support. In fact, the patients who lost weight and stayed in remission, their spouses also lost substantial amounts of weight.
Instrumental.
Yeah.
Instrumental.
Yeah. So it's crazy how important social connections are. And then, I have to give credit to my chair of medicine. She's no longer here at my health system. She left a few years ago, which was a big loss to me. But Dr. Rachel Lovins, if it wasn't for her and her mentoring, and I remember when we did the grand round, she was so excited. She actually Facebooked on our health system's Facebook page, and she's like, oh, there's a grand rounds and they're serving plant-based breakfast, which, it was so kind of our organizers. The person who coordinates the entire grand round, she's our secretarial staff. She handmade plant-based cookies while at that, and they never serve breakfast at grand rounds, but they actually made sure that they do it for us. So I had, the interest of the colleagues was really such an important piece of this story.
That's what I took away from it was, the catalyst was, you wanted to find purpose and joy and meaning behind the work that you do. You spent so much time, you went to school, you did residency, you did fellowship, you served your patients for a number of years, but you still ended up at a roadblock. And I'm sure a lot of physicians or people that know of physicians and fellow healthcare professionals alike would know that it's a very long, arduous road. And, to be able to cross that and then still hit a roadblock can be very, it can really weigh you down. And that article that I referenced about you talks about burnout. And a lot of, people that don't know, physician burnout is a very real thing. It affects us all the time. There's also a really high number of physician suicide, all these different wellness trends, especially post-pandemic, has never been more noteworthy. And so to be able, and I'm sure you can agree, lifestyle medicine is almost like that breath of fresh air. And what's great about it is that it could be applicable in almost every specialty, right?
Yeah.
And that's a beautiful thing.
Yeah, that's 100% correct. I cannot think of any specialty. Can you that would not, directly benefit?
It's so inclusive. and so
It
inclusive,
is so inclusive.
and it
It is,
doesn't shut anyone
it's
out. And that's what I
foundational.
love it.
It's foundational.
It
Absolutely.
is.
Absolutely.
It is. Hey guys, what's going on? This is Dr. Colin Zhu, aka the Chef Doc, and I just wanted to extend my gratitude and appreciation for you for listening to this episode. We are always looking ways to evolve and give back, and we also understand that a large part of our audiences are our fellow healthcare professionals. And so we've decided that we're going to create continuing medical education for our listeners. And it's not just for doctors. We've partnered with CME Phi to deliver continuing education for not just doctors, but also nurses, nurse practitioners, physicians associates, pharmacists, dentists, dietitians, and dietetic technicians. This is just another way for you to be able to get continuing education while listening to our great episodes. So how does it work? Basically, how it works is there will be a hyperlink provided in the show notes, and you click on that, and you're given a couple of reflective questions. And once you're done with that, then you are awarded 1 CE credit per episode. And so basically have at it, have fun, and also gain education as well at a nominal cost. And so thank you again for listening and following Thrive Bites podcast, and we greatly appreciate it, and we'll see you on the next one. So let's dive deeper, into the growing issues that we have. Give us some numbers in terms of, where are we at with, let's just talk about type 2 diabetes, in terms of incidence, prevalence. Let's break down what those words mean, that are affecting Americans, and how does lifestyle medicine play a role in that?
Yeah. So, diabetes, as I'm sure there's not an audience member who's not heard of this or has not actually had somebody that they know suffer from this. But it really is the scourge of the 21st or the 20th century, right? When I present nationally, there are some fun questions I kind of put out in order to gauge and engage audiences. So one of the things that I like to talk about is, in 1980, the year 1980,
mm-hmm.
and comparing that with the year 2014, which is 34 years down the road, right? How much has the prevalence of diabetes in the US increased in those 34 years, less than 4 decades?
I probably would say 5 times.
Yeah, so you're very close, 4 folds in less than 4 decades. Yeah. And, this is a somber statistic. There are 2 of them, actually. One is, so, somebody who's got type 2 diabetes, how much less can they expect to live compared with somebody who does not have diabetes? According to CDC data and, in numbers, are they going to live 10 years less, 5 years less compared with somebody who doesn't suffer from diabetes?
I would probably say 8 plus.
Yeah. So at age 50, if somebody has type 2 diabetes, they can expect to live 6 years less compared with somebody who does not have diabetes. Now, there are 2 things. One is this is American data. And second, this is at the age of 50. So, if somebody gets diabetes at the age of 20 or, 18 or 40, this is not data for them. Their life expectancy might be much reduced by a matter of decades. Just getting diabetes cuts somebody's life short by that many number of years. And the other thing is, this is the US data. In the US, we have sophisticated, sort of healthcare technologies to save people if they come in with a pneumonia or with sepsis. People can survive. But if you look globally, if you look worldwide, which is where diabetes is actually now multiplying, if you look at the Middle East or South Asia or East Asia or, the developing South, you are not going to have life expectancy shortened by 6 years. First of all, diabetes will start early, which it's already starting early. And the other is it's actually going to cut more years because they don't have access to fancy technologies.
Right.
If people get septic shock, they will die. They don't survive that. So that's, again, another sort of sobering statistic. And I will not bore you with statistics, but the last one that comes to my mind is, how many percentage of diabetics die before the age of 70? So let's say, all the diabetics that there are in the world, which right now I think there are over 400 million diabetics in the world. How many of them can expect to die before the age of 70? And 70 is the age that has been defined by World Health Organization as premature death. So if somebody dies before the age of 70, that's premature. They should not die that early. And how many of the type 2 diabetics living in the world can expect to die prematurely?
Probably say upwards to a third.
Yeah, 48%. So almost a half of the diabetics will not make it to 70th birthday. And so this is what diabetes really is. It is the plague, the 21st century plague, really. And, we have to act because, what I see is that diabetes is affecting kids and younger adults. When I was a trainee, which was, agreed it was 2 decades ago, but when I was a trainee, I had not seen diabetes in kids. I mean, type 2 diabetes. I'd seen type 1, right? But not type 2 diabetes in kids. And I did not see the tsunami of gestational diabetes. Now my clinic is like flooded with gestational diabetes.
Yeah.
And, I think 1 in 10 pregnant women, or maybe even more, pregnant women can expect to get diabetes during their pregnancy now. When I was a trainee, it was a rarity to have a pregnant woman with diabetes.
What do you think this exponential growth that you mentioned, the fourfold since the 80s, what do you think contributes to that almost roller coaster ride of that trajectory? What has changed before, the 80s? What was implemented? What was modified? Can you share a little bit about that?
Absolutely. I think it's our lifestyle. It's the, sort of the intersection of lifestyle with culture. So, when I talk about lifestyle, it's all the 6 pillars that, hopefully we'll get the chance to talk about bit by bit. But it's our food, number 1, our food environment, the modern industrial food environment, our critical sleep deprivation pandemic. In the 1960s, an average American adult slept 8 hours at night. Now, in the year 2010, an average American adult sleeps on an average 6.7 hours at night. Or at night, you're obviously not talking about night shift workers, but 6.7 hours on an average. So we have shaved off 1.3 hours of sleep from an average adult's life. So that's another pandemic. It is our, other substance addictions, whether that's alcohol or certain substances, but also processes, social media addiction. And then last but not the least, our stress management and our relationships.
Yeah.
So all of these, these cultural lifestyle intersection is what has led us to this moment. I think we should talk a little bit about the food environment now, because, that's kind of the chunk of diabetes pathogenesis. And it's a fact that in the 1960s, or even as late as 1980s, the average person ate 300 calories less than what the average person eats now. And that's true across all continents, all ages, all sexes. So, children, adults, on an average. It might be true that people in the developed world are eating maybe 600 or 700 calories more than their counterparts did in the 1960s. That number may not have changed much in certain sections of Africa, right? But if you take a global average, 300 calories on an average per person, per capita more. And a lot of this is industrialized food, ultra-processed food.
Yeah. And not to mention, especially the pandemic that has highlighted this, you have food deserts, you have poor food access, you have socioeconomic, disparities, which lead and correlate with health disparities, and so many different things jumbled together that we are now being more and more aware of. In terms of lifestyle medicine, so bringing it back, we talked about the pillars. What are you seeing in your clinic? Fast forwarding a little bit, right? What have you seen once you've had some time to implement this through your programming, through the coursework, through, your patient population? What have you seen that has made you go, wow, this stuff really works? It's reinforcing, it's reaffirming. Let me keep going with this. As opposed to someone's, listening to this and say, oh, it's just, eating less and moving more, right? What would you say to that?
Yeah, it's not as simple as eating less and moving more, right? And you and I both know that. There have been several sort of aha moments since I began lifestyle medicine. It has been a gift that keeps on giving, really. Now there are some patients who radically transform themselves. I'll tell you a story, because stories are always such a, stories really kind of bring the message home better than, data can or statistics can. Statistics are cold. So I had a patient in her early 60s who had, BMI of over 50, and she was wheelchair bound because of knee arthritis. Now she had suffered from breast cancer in her early 40s, and she had had type 2 diabetes for over a decade. She was already on insulin when she came to see me. And she had the most supportive spouse. So she had a typical, what we call a standard American diet in SAD. She would eat microwaved entrees and boxed foods, cereals for breakfast, etc. Right? So typical food. And she attended, shared medical appointments with us. So as you know, shared medical appointments are one modality which us lifestyle medicine providers can utilize in order to create this group where you can actually spend a lot of time, because who has time in 15 or 20-minute appointments to tell each patient to eat better and to,
Right.
really kind of go down to the minutiae. Nobody has the time to do that.
Mm-hmm.
So shared medical appointments give you the luxury of time. And they also give you something which is critical, which we talked about in the beginning, which is the social support, your circle of friends. So there are other patients with diabetes or cholesterol or blood pressure or, breast cancer or something else that all come to that common place of learning. It's a community of learning. And there is this, relatively luxuriant, unbridled time with the physician and also with our lifestyle medicine team, which in our case is a wonderful registered dietitian. I have to shout her out. Her name is Piper Tobler. So, we cook something fun, which is, we don't have a fancy kitchen. We have only a microwave. So Piper brought in her NutriBullet from home. And she decided to make a smoothie. And she had a hidden ingredient, a secret ingredient in her smoothie. And the participants had to guess what it was. And, she had bananas in there and maybe the cocoa in there and, almond butter or something else. But there was a hidden ingredient. And none of the 10 patients who were there could guess what it was.
Uh-huh.
It was a cauliflower.
Ah.
We had hidden, I think, a half sort of a flower of cauliflower, like that half vegetable in there, and nobody could taste it. So my patient who, I'm talking about, she drank that and loved that. And her husband commented, if we ate like that all the time, then we would not have half the diseases we have. And this is, right before the pandemic began. So that, I think, was a catalytic moment for both of them. And she never looked back after that.
I love it.
So she started not eating, her typical diet and started eating real food. She started eating more vegetables now that she knew, from hands-on experiential learning that vegetables can taste good, right? And so, our job was to show, not tell. And we showed it to her and she saw it. And she's a transformed woman, and as is her husband. And they took it up and, within less than a year, she lost a huge amount of weight. She was off insulin.
Mm-hmm. You said her BMI was over 50?
Over 50. And now she might be, I think her BMI might be mid-30s now. Now, this is, before pandemic. We are talking about now post-pandemic, right? At some point of time, I think it was in 2022, beginning of 2022 or late 2021, she decided to go through bariatric surgery. And that's, a choice that she made. And that's completely wonderful and honorable. And so, but before she went for bariatric surgery, the only diabetes medication that she was taking was metformin.
Wow.
And now she's off metformin, right? So this is a remission case, right? This is somebody who's had diabetes for over a decade, has already been on insulin, multiple shots, not even like insulin daily, once daily.
Yeah.
Who's already off all the other medications and is only on metformin. And now is off of metformin. I think her last A1C was in the high 4s.
High 4s. Wow. What was the highest for her for A1C?
When she saw me, I mean, the reason she came to me was because she had called me. She actually used to see my colleague. And she called me after Halloween because the sugars were running in the 300s or 400s. And, she had called me after hours, but I'm like, okay, so what you eating? And she's like, I have a lot of Halloween candy left over. So I am eating that. And
she's
so
going to eat it until the next Halloween.
Yeah. So she ended up seeing me when her sugars were, and so I brought her in urgently. This was an urgent sort of a consult, right? So her sugars must have been in the, with 300s and 400s, A1Cs are typically higher than 9.5 or 10, easy.
Yeah.
So yeah, this is one of the fantastic story. I mean, she's obviously she's a mind-blowing story, but there are so many other stories which are less dramatic. But, patients stop using insulin sometimes. And in many cases, they are able to come off of very expensive medications.
Yeah.
So, Dr. Zhu, this is a fact in the modern America.
Yeah.
That many diabetic patients choose an employer, choose an employment based on the healthcare insurance plan they will get at that employer, right? So they don't choose their position, their job position, because that's their dream job, but that's the job that really gives them meaning. Yeah. They only choose that job because they have the best insurance plan. This is the reality for most of my patients, right? So
you know what's funny? I just interviewed someone from the UK, and they have a public health system there that's socialized medicine. You could have an accident, you can have an operation, walk out without having a bill. And to add to your point, that's the issue, is that people have to find jobs based off of their insurance. And sometimes people pick partners because they have good insurance. This is really sobering, types of ways that we're going about life. But I do want to comment on what you just said before. Two things you mentioned was shared medical appointment, which is basically you're in a classroom, peer-to-peer interaction. That's number one. Number two, there was cooking involved in this medical appointment. I mean, how many medical appointments can you say, there's cooking involved and you're there with your peers? So a part of it is that you don't feel alone, and you feel like you're not the only one that's climbing this insurmountable mountain.
Exactly. Yeah, no, this is, many patients will say that this is the only appointment that they actually look forward to going to, right? They, in fact, when we did our shared medical appointments virtually during the pandemic, we had a lot of seniors. There was a time when only seniors were showing up to these Zoom sessions or these, epic electronic video sessions, because this was one of the only social interactions that they were perhaps having that was adding, meaning and joy to their otherwise pandemic life,
Yeah.
And when the Surgeon General, recently they brought out, the Department of Health and Human Services, they have published an extensive 81-page scientific advisory on the pandemic of loneliness in our country. Yes. And somebody asked me, how can physicians address loneliness, right? If it's one of the biggest risk factors, it's more risky than smoking 15 cigarettes a day, or, being obese or being sedentary. But loneliness is the bigger killer here. And it's more pervasive. More people are lonely than are smoking cigarettes or are, sedentary.
It's our new silent killer.
It is
back when hypertension was the big player on the street.
Yeah, no, we are actually, during our grand rounds, one of the things that my ex-chair of medicine asked me to do was to do, what we call Schwartz rounds on loneliness among providers. Yeah. And I remember presenting my own case of loneliness, and the conference room was filled. And I had, brought in like articles on loneliness from NEJM, and I really wanted to talk, but I could not talk. The audience would not stop talking about their loneliness. And I'm like, okay, the whole room had talked about how they felt lonely, on the floors, in the office, in some other patient care scenario. And this is just among, healthcare professionals. But anyhow, one of the interventions, the reason I'm talking about loneliness is one of the interventions that we can do as physicians, perhaps is a shared medical appointment. Because if we talk to a patient, it's still a physician-patient dynamic, right? It's still a power differential.
Yeah.
But when a patient talks with a patient, I remember there was a patient case scenario where, one of my patients, she was struggling with homelessness and alcoholism. And then one of my other patients came to her rescue and told her, what, I have done this a decade ago, and I have been able to do this, this, and this. And she gave her the resources in that session. And so, here is this patient who sees another patient who has dealt with that. And they are exchanging resources, which sometimes, as a physician, I may not know. I may refer her to social worker. She may not be able to schedule a meeting with social worker. There is many sort of avenues for loss and translation of therapy, right? Yeah. But one of the things we can do as providers is maybe create an environment where people will feel less lonely and less threatened.
More welcoming, more accommodating, and it gets us part of the conversation. It gets us involved in the conversation, because we're not super versed in terms of how to be like this. We're more like this and like this.
Yeah.
And so when we're part of the conversation, when the patient is part of the conversation, and they know that, their peers are also part of it, it gets them feeling like, okay, I think I can make change. I can be a contributing factor to my own wellness and healthcare. Shifting gears a little bit, let's talk about remission. We talked about, lifestyle medicine. We talked about the pillars. We went over on how to apply it, share medical appointments involving, culinary medicine into this. So let's talk about remission. What does that mean? What is the definition of remission for diabetes? And what does that involve? Because we know that diabetes is a multidisciplinary team-based approach and involves a lot of different players, not just yourself at the helm, but so much. But when we're talking about lifestyle medicine, what does that mean in terms of diabetes remission?
Yeah, that's all the craze now. I remember we created the expert consensus statement from the American College of Lifestyle Medicine on diabetes remission. When I say diabetes, it's type 2 diabetes remission, which is 95% of all diabetes, really. So remission essentially is defined. Remission, it's kind of like putting that disease on a little bit of a back burner. We hesitate to use the word reversal because, reversal would imply that the pathology has completely gone away. And it's not as scientific. Remission is something that we have data on, evidence on. And now through, multiple randomized clinical trials worldwide, not just here in the US. In fact, most of the work actually comes from Diabetes UK. But also other places, including the Middle East, etc. We found out that lifestyle interventions, intensive, you have to dose the lifestyle appropriately. If somebody has significant pathology, you have to give them significant dosed lifestyle intervention, can actually take the diabetes away. So that's technically defined as maintaining an hemoglobin A1C of less than 6.5%, which is the official, criterion, the American Diabetes Association criterion for diagnosis of diabetes, for at least 6 months off of any medication that is used specifically for the purpose of controlling glucose. And that A1C does not have to be done by a blood test. You can actually wear a CGM, a continuous glucose monitor, that can also give us an estimated A1C. So 6 months and less than 6.5%, ideally off all medications. And it's not a new concept, actually. It had been around, back when I was a trainee 2 decades ago. The prevailing paradigm was, diabetes is irreversible. It is an inexorably progressive condition. Once you get it, it's a relentless march downhill from there, right? In fact, if as an endocrinologist, I'm doing my job well, I'll keep you alive long enough for you to be able to look forward to this day of starting insulin, right? That was a paradigm when I was a trainee.
That was something to look forward to. Delay me until I get, these shots.
And then, obviously bariatric surgery came along. And, lo and behold, people who've had type 2 diabetes for a decade or so were able to stop needing diabetes medications, right? So that's when remission actually became a thing. And now we know, now, of course, there are pharmacotherapy options where people can use, weight loss medications, etc., to lose significant amount of weight to go in remission, right? But of course, lifestyle medicine is the absolute, sort of the substantial, the cardinal approach to diabetes remission.
Yeah. And, not to say to everyone, go get, bariatric surgery, because there's also, ill effects and side effects and complications, because it is surgery at the end of the day. And I'm glad that you pointed out your first case study about your patient, because that's actually what most, preoperative care would look like. They would want you to make substantial lifestyle changes, because at the end of the day, if you're not making these changes, whether you have the surgery or not, it's not going to make a difference. There's been a lot of reoccurrence rates in terms of getting back that weight and, the disease condition. So Mahima, this is great. I definitely want to kind of go towards, closing out. And for those that are listening, for those that are struggling with, diabetes, that knows of someone that's struggling with diabetes, you're in Connecticut, right? And so what is it, would you say, would be the best thing for patients that are listening to kind of be, let's just say they want to be more proactive than reactive? To say, Dr. Mahima, I don't want to be on these medications forever. What types of questions should they be asking of themselves, whether to take their health by their own reins, or if they're going to their primary care physician or specialist, what can they ask, they do in terms of their roadmap? What can I change? What kind of other therapies I need to seek out? Where can I find a lifestyle medicine endocrinologist?
Yeah. So that's a wonderful question. So number one thing, that a patient who has diabetes and they are looking to put it in remission, basically live without diabetes, not live with diabetes, and that's a noble goal, really. And there are studies that show that people who have type 2 diabetes, particularly in the beginning, in the first 6 to 8 years of type 2 diabetes, a lot of this can actually go in remission and stay in remission. The first resource I would recommend they should lay out is their support team. Who are there, who has got their back, their own personal sort of family support, and then their professional support, which includes their physician or provider or educators or, any other number of kind of their professional support team. And you can find lifestyle medicine certified providers on the lifestylemedicine.org directory. If you just, Google lifestyle medicine board certified providers, you can find them in your vicinity by your zip code. And nowadays, it's becoming sought after thing. In fact, American College of Lifestyle Medicine is even bringing out a certification program for remission of type 2 diabetes. So there will be providers who are actually certified in how to help patients remit their type 2 diabetes. They've actually received a certain number of hours of credentialing to do that. And they know how to intensively dose that therapeutic lifestyle therapy, right? So they can look it all up on Google. Number one, that's their primary, task, to find out exactly what support they are lining it up, and, just jot down, this is my team, because you can't do it alone. Remember, wellness begins with we, WE. So they will want to do that. And then, after that, the rest of the pieces are relatively, I think most patients know what it is. It's the 6 pillars. It's, what works for your life. And you're the only person, you are the expert in your life. You know what kind of a diet program will work for you, whether that's 100% whole food plant-based, or is that, a Mediterranean style of diet with some, fish in there. What will work for your family, your kids, if you have, or any other, family members that are with you, and your own, work hours, etc. So making sure you have a plan in terms of your, not just your diet. If it's your sleep, that's the problem. I've had several patients who were doing night shifts or were doing third shifts who have benefited from fixing their sleep schedules. That's how they got their diabetes in remission. So, identifying what it is that is the biggest chunk of the, lifestyle problem that will give you the most dividends. For some, it's stress management. They might find that once the stress thing comes in, their stress response is completely, sort of, it counterproduces what they have already lined up. So they may have 100 items on their journal and they will not achieve anything because the stress gets to them. Yeah. And in that case, they have to, figure out how can they modify their stress response, because it's not the stress. There will always be stress, but how do we respond to the stress that's there? Yeah. So the rest of the pieces are, in my opinion, they are, people know what they need to do, but they have to have their support.
Yeah. Yeah. And I think the biggest highlight, from your story was, if you didn't have that support, would you have ended up here at this moment, right? So it's huge, huge, huge. And, definitely people that are watching, don't make these decisions lightly or by yourself. Definitely consult your primary care, your specialists, make sure you ask your medical professionals on how to get started. So Dr. Mahima, thank you so much for taking out the time. One last question before I let you go is, this podcast is all about, living and breathing and thriving at the end of the day. What are 3 things that you do for yourself? We talk about self-care, right? That you do in your own routines that help you thrive, help you get up out of bed every morning, helps to feel that fire, helps you to keep pushing. What are those 3 things that you can share with us?
Okay, this is so interesting. I have improved over time, and I have my lifestyle medicine fraternity. People like yourself, our board of directors team, our other lifestyle medicine providers that I'm in touch with. We are doing this Move in May challenge where we are keeping each other accountable to exercise and get a certain number of metabolic equivalents of exercise each week, right? Steps or whatever. So I feel like, for me, the engagement with others, I really learn from others. I'm a social learner. So I have learned from you. I've learned from Dr. Frates, Susan Venegas, all of my lifestyle medicine folks. That's my number one self-care, to connect with people who inspire me at a very, at a very human level. I, feel like I need to love and to belong. We all long to belong. And this is a place where I belong. I feel like every time I look forward to going to lifestyle medicine conferences and meet my kin, it's not just I'm meeting my colleagues. It feels like I'm meeting, real friends, like true friends. So number one is connect. And then, doing fun things, making it fun. I love to experiment with foods. I know you're a culinary medicine expert. So I love cooking and coming up with novel recipes. Like yesterday I made a teff porridge. Yeah, with mangoes or blueberries or stuff. So I love to have fun. That's the second one. Make it fun. If you're having, foods that are healthy, making them tasty is kind of a fun thing to do. How can you make broccoli tasty? That's a fun thing to figure out, innovate. Mm-hmm. So that's the second thing that I feel helps me kind of thrive. And I think the third thing is over time, I have learned how important it is to have, the rest and repair and regenerate part of the equation. Because, we're always move and go. Mm-hmm. But to be able to, kind of activate the parasympathetic nervous system and, get the 7 to 8 hours of sleep. And sleep was my biggest challenge, when I talked about the preterm birth. And a lot of the problems that I had in my earlier life, I think a lot of them were when I wouldn't sleep very good, maybe sleep barely 2 or 4 hours at night for, a stretch. So understanding the vital role of, breathing or reading, restorative things at night, basically dimming the lights down, not have, bright lights up in the evening, keeping my phone out of my bedroom, which again, something my husband inspired me to do. Those are also important things, that part where you're not always move. When the evening comes, start shutting down, set the stage for this is the time when relaxation should kick in. And I have taken that more seriously over the last maybe 1 year or more. And that I think is helping me now.
Awesome. Well, Dr. Mahima, again, thank you so much for, your experience, your expertise, your light bulb moments. I love them all, the stories. Definitely a pioneer. Please continue to do the great, amazing work that you do. And, just a shining example. And can't wait to see you in Denver later this year. So
yes, I have to thank you, Dr. Zhu. You are a pioneer. You inspire me. It has been my utmost honor to be connected with you through the American College of Lifestyle Medicine. I'm very, humbled and really motivated by all the work that you have done and all the, sunshine that you bring to the world. And I want you to keep going for me, for your fraternity, for your patients, and for all the lives that you touch. So
I appreciate that. That means very, 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 very much beyond words. So I really appreciate it. Thank you very much. Again, thank you so much. Guys, thank you so much for watching another episode. If you like this, please like, comment, and subscribe. And if you feel like this is a benefit for someone else, please let them know. Until then, please say goodbye to Dr. Mahima. Hey guys, we hope you enjoy that episode. If you like that, please like, comment, and subscribe. And please follow us on Apple Podcasts, Spotify Podcasts, and anywhere that you listen to your podcasts. And if you felt that this was a benefit for someone else, please let them know. And also remember that the first 5 seasons, 150 episodes, now can be seen and heard on our new The Chef Doc app. And don't forget to give us a 5-star rating, and we greatly appreciate it. And we'll see you on the next one.